Okay, welcome back, everybody. We are in the home stretch, and we hope that this afternoon will be full of valuable information in terms of what we're doing in Hawaii to be dementia capable. And before the break, Michelle talked about those pro tips, those words of wisdom, and in fact, that has been so valuable for us over the past few years as we have strived to build this Hawaii Alzheimer's Disease Initiative. So I'm going to give you a little bit of historical context and background for how we've led to this moment, this training today. So we received a federal dementia grant in 2015 that created the Hawaii Alzheimer's Disease Initiative, a project of the UH Center on Aging. And myself, my name's Christy Nishita. I'm with the UH Center on Aging and also the principal investigator. Other members of the team include Dr. Rita Bell Fernandez, as well as Jody Michon, who's back there. And the mission of our grant was very broad: to improve the supports and services in the community for persons with dementia and their caregivers. So a very broad mission. And the work that we did fell into two buckets. So I'll very quickly talk about those two buckets. Number one, we have strived to provide education and training on all levels. We offer dementia-related training to family caregivers and the general public at the paraprofessional level as well as the professional level as well. So I just want to point you to the resource, which is our website. You can see the web address up there at the top. And you can find a lot of resources, including how to order some of our talks and presentations. So this slide here is our speakers bureau, and you can see the list, I think, of topics that include palliative care, brain health, non-medication strategies, long-term care financing options. And I will say that I apologize, these are not in your slide deck if you're searching around. It'll be in the emailed version that we'll send after the training. We're also partnering with Dorothy Colby, who is certified in the positive approaches to care. And she gives a wonderful series of workshops. You'll find the flyer there on our website as well for the topics that she covers and the dates, and those are offered at Kahala Nui. You'll also find there some very practical tools. As I said, we've learned a lot over the past few years, and the Barclays have been wonderful mentors and advisors to us, and this is an example. We have adapted to Hawaii a national Act on Alzheimer's tool called this care coordination practice tool. And it's actually a companion piece to some of the training that we offer. This is the cover page of about a 5 or 6 page tool that walks care coordinators, whether you are a nurse or a social worker, but serving in that capacity, walking you through the process. You can see the mini cog over there to referring to the physician for a workup and what happens after that in the care coordination process. So that's the care coordination practice tool. And there's a similar piece that we provide to the clinical providers, and again, adapted from national best practice. We've also been giving grand rounds at different hospitals, and this is in partnership with the School of Medicine here and many from the Department of Psychiatry and also the Department of Geriatric Medicine. So I just want to say that these are all educational and training options and that are available to you. So please talk to Jody, myself, or Dr. Fernandez afterwards if you're interested in learning more and bringing those to your organization or to any of the caregivers that you work with. So the second bucket that we're working on through our HADSSP grant is these 3 services. We are creating new services in the community, and I'll go through each of these one by one. The first thing is that we are creating memory clinics within federally qualified health centers. And these memory clinics are held once a month, and they provide coordinated care for families with dementia. So the person with dementia can come with their caregiver, and in this once a month clinic, They rotate through different stations, and you can see the stations inside those circles, and they include a geriatrician, a psychiatrist, a legal advisor, a dietitian that talks about brain-healthy foods, including the MIND diet that Dr. Barkley referred to earlier, and caregiver education. So right now here on the island, Kokua Kalihi Valley has this memory clinic, although it's only open to those living in Kalihi Valley. But Kalihi Palama is our newest memory clinic. So I can have Dr. Fernandez answer questions about that later too. She's leading that charge. And the second one, we're creating memory care navigators. And again, the Barkleys were instrumental in creating this model and working with us on this. And memory care navigators, their role is to educate, support, and connect. Very simply, educate, support, and connect. And we're partnering with the public health nurses on this effort. They are open to taking referrals for anyone that needs assistance, and we have a public health nurse representative here to talk about in more specific detail what she can offer. And then finally, very quickly, we are offering the Savvy Caregiver program. It's a support group-based dementia caregiver intervention. It's 6 weeks, 2 hours each class, with a lot of strong evidence behind it for improving the outcomes of caregivers, including self-efficacy and reducing burden. And so through the 6 classes, caregivers are learning, practical skills for how to address challenging behaviors and improve their confidence. So those classes are being offered currently on Oahu, so happy to talk about those as well. So historically, that's the first federal dementia grant that we got in 2015. And luckily, we have another federal dementia grant that has helped to bring you this training today. And I'm going to call upon Debbie Shimizu from the Executive Office on Aging to touch upon that.
Thank you, Christy. So the Executive Office on Aging received a 3-year federal grant to build dementia capability into the No Wrong Door system. The federal grant that we got will run from this year, 2018 to 2020, and it involves myself with the Executive Office on Aging, and then Christy and Rita Bell from the Center on Aging. At the same time that Christy got the HADDSSP grant, the Executive Office on Aging received a grant separate from the dementia grant to build a No Wrong Door network. And so this is on the systems level. We are bringing together state agencies, and we're calling them doors. So the doors are the Developmental Disabilities Division, Children with Special Health Needs Branch, the Adult Mental Health Division, MedQuest, Division of Vocational Rehab, the Veterans Health Administration, the AAAs, who are the county area offices on aging, and the Centers on Independent Living, the 2 agencies we have in Hawaii, Access to Independence and Aloha Independent Living. So these are who we are calling doors, and the No Wrong Door system, if you can imagine this, means that no matter which of those agencies you come to, enter their door, you will receive, they will take some common information, and then they will be able to do a streamlined referral to wherever the person needs to go. So you don't just get a phone number and say, here, call this number, and never know whether or not the client actually calls that referral. So we're trying to streamline the referral and do that warm handoff that Michelle talked about earlier. So the client will be able to more easily get to where they need to go. We have, in the No Wrong Door grant, we had 3 buckets. So we said that we were going to develop an integrated network of the state agencies. We were going to train the staff at those state agencies to be more person-centered. You will be hearing more person-centered because the federal government is mandating that for MedQuest agencies as well as for developmental disability agencies. So person-centeredness is the way that the federal government is moving agencies to go. We also are developing additional sources of funding so that when the grant ends, we have a way to sustain this network. Our goal with the No Wrong Door grant was to support all individuals with long-term services and supports in making informed choices about their supports so they can remain independent and lead meaningful lives. Our dementia grant was to build upon the No Wrong Door system. And our goal with the dementia grant was to have persons with memory loss or dementia and their caregivers receive person-centered, coordinated screening, assessment, and referral within that No Wrong Door system. Where we are with the No Wrong Door grant is that we are, in terms of the first goal to develop a network, we established an advisory committee, and we are piloting on Oahu an electronic referral tool. So the doors have an electronic referral tool that they fill out information from the clients, and then they can send that referral via the internet to the referring agency. And the agency who picks up that referral, an email will go back to the original agency who sent the referral to say, hey, we got it. So it kind of closes the loop on what happens to that referral. Because oftentimes you never know after you make a referral what happens. This kind of is going to help to close that loop so that we won't have any gaps in service. In terms of the person-centered counseling, we are training the door staff to be more person-centered, and 5 of the agencies are also being trained in person-centered organization. So not only the line staff are being trained, but also the supervisors and some of their leadership will be more person-centered, how to create an organization that is person-centered so it supports the line staff. And then for sustainable funding, we have to submit an application for a Medicaid cost allocation plan. Hopefully we can get some Medicaid reimbursement for some of the work that we're doing. And that would be how we would sustain our funding. In terms of the dementia grant, today you're being trained by the Barclays, and next after, in terms of training and education, if next year you want your staff to have some training or want to refresh some of the current staff or yourselves who are being trained, but you want some refresher, Dr. Rita Bell Fernandez will be able to come to your agency to do a training. We wish we could bring the Barclays back every year, but unfortunately we can't unless we get another grant, or maybe they'll volunteer to come back. In terms of standardized tools and protocols, you're being trained on the 88 and the mini-cog today, and we are trying to strengthen the referrals to the doctors and the ADRCs in terms of offering long-term services and supports. We're going to be working on that. And then in terms of community resources, we'll tell you some community resources today. You'll be introduced to some of them. And then the University Center on Aging will be putting together an inventory of resources, and we'll make that available to you in the next couple of years. So in summary, the process that we are thinking is that all of the doors are going to be trained. A person will come through the door, they'll get training they'll get a screening through the 88 or the mini-cog, because you guys are all now experts in that, and you will be able to make a referral either to the PCP, to the service coordinator if they are a Medicaid client, to the ADRC, or another community resource. So we have invited some of the resources here today to talk to you about what they offer. And we are going to start with Alzheimer's Association. We have Lynn Moku.
Thank you, Debbie. Good afternoon. I'm Lynn Moku. I am the Program Specialist for the Alzheimer's Association Aloha Chapter here on Oahu. I'm a part-time employee. I've been with Alzheimer's Association now for 8 months. And I think the one thing I want to tell you that I'm most proud of, in the last 8 months, we have talked with over 800 people. That's a pretty good number, I think. We're in the process of really rebuilding our programs, the kind of programs where we're going out into the community and meeting with people. And just to give you a little information, we do have several core programs, information and referral services. I think most of the agencies have a referral service. We also do, and we're in the process of updating our resources. Care consultation, we're able to do both individual and family consultations. So we're talking to more of the families. You know, I'm sure with the speakers, you know how Alzheimer's and dementia affects the families, especially caregivers. So we're getting a lot of calls about dementia. It's surprising, I think, that people really don't know about dementia and Alzheimer's, and even though they receive the training or they read about it, they're still almost in denial in working with their loved ones. So the care consultation is another big program that we're doing. The education programs, that's what I've been focusing on in the last 8 months. We do caregiver training. What we're doing right now, we've been working with Castle Medical Center over at their wellness center. So we have a program set with them for the next 12 months. The education programs precede the support group meeting. So our program starts from 5 to 6, and then the support group meetings are from 6 to 7:30. But that's been a major accomplishment for us to get out in the community and offer these programs. We're also doing the caregiver training programs out at Ilima at Lehano in Kapolei. That's another area where we had a very small support group and decided if we could offer the education programs to help build the support group, but also just getting out into the community. We had programs at the office, but people were not coming to the office, so we decided it would be better to go out and meet their needs. And we did learn that they're not going to come into town to attend programs. So that's really been a major accomplishment for us. At the same time, we're doing a lot of public education, going out to senior centers. We went out to Mililani and spoke to over 70 seniors in their senior club. That was a really good turnout, you know, to those people would never have come into town to attend one of our programs. So we're finding just by going out into the community, we're really getting the word out about Alzheimer's disease, dementia, and at the same time being able to offer training to people. Our support groups, I think, are probably our most important program, the one with the most impact. We have 7 support groups across the island, and we want to form more groups. The groups are led by trained facilitators. They're not staff members. And we are looking for volunteers to become facilitators for the support groups. Ideally, we would like to have a support group in every community. So that's another major goal that we have. I don't know if you're aware of the Safe Return, the Medical Alert and Safe Return program. That's also one that we're involved with. And just this month, we've done 2 trainings with first responder trainings with the Honolulu Police Department recruit class. So we're also involved with the first responders training. We're planning a training for nurses' aides in a couple of months on dementia training. That's something that we've been wanting to do for a while, and we're finally pulling that together. We also have our trial match program, which is a program that allows people like you and me to participate in clinical trials. The trials are, they're actually doing trials here in Honolulu now. There are a couple of trials that they're doing. But it is a chance for all of us to participate and try to find, of course, a cure, the cause, the cure, but also ways that caregivers, services to caregivers can be improved. So clinical trials through our trial match program. That's really what we're doing right now. We do want to work closely, a lot closer with healthcare professionals and the doctors. So we're going to be going out and meeting with doctors and providing more information to them about Alzheimer's also. Do you have any questions?
I know a lot of people cannot go to support groups because they can't leave their loved one at home alone. Are there any support groups where they can bring the person and there's maybe a program for them while the support groups happening?
Not yet, but we have talked about the possibility of doing that. And also, we will be offering one program for people with Alzheimer's, newly diagnosed people in the early stages of Alzheimer's. Right now, all of our programs are geared to caregivers and the general public. But it is something that we would like to do, because you're right, it's very hard for people to attend a program and not have someone to take care of their loved one. No other questions? Thank you. I have 2 brochures for you outside on the table. One is, this is a program brochure about our office and the services that we provide. Know the 10 Signs is probably our most popular brochure. This is something that all of you can use to identify the signs of Alzheimer's and dementia. But also, when you see this, when you come across other people that might have dementia, you can, at least, at the very least, refer them to our office. If you know somebody that is exhibiting the signs of dementia, please get them to a doctor so they can be diagnosed and they know what it is. Is it Alzheimer's or is it something else? That early detection is very important. Well, thank you very much.
Next, we have Mary Gaddam. She's with the Public Health Nurses.
Hi, everybody. So I'm Mary Gotham. I'm a public health nurse. Forever, I've been a public health nurse. And I'm a geriatric nurse all the way around now. I've got my Medicare card. Anyway, public health nurses, we're statewide, we're under the Department of Health, and so we're paid for by the taxpayer. And so there's no charge for the public health nurse to come out. We go by geographical areas, and on Oahu, we have 5 sections. And I thought maybe there was going to be this up on here, but anyway, there's a handout outside that tells all about what we do.
Oh, no. Here.
Okay, is there the front page too that says what the services are? Anyway, so this is where all the sections are on Oahu, and anyone can refer to us. And although when you look at our form, it talks about you have to be 60 years and older, this was kind of made for my program because I'm unique on this island. I only carry 60 and above frail elders. But public health nurses do from the womb to the tomb. So you can refer anybody at any age who has a health need that could benefit from some intervention. And I would say public health nurses are natural-born navigators. That's what we do. We help people navigate through all of their health conditions and things. And so we were so fortunate 2 years ago, about 19 of our public health nurses statewide got trained by our Barclays. And thanks to Christy and Jody, we have a great online training so that many more of our public health nurses are going to be dementia-capable navigators. So call on us. The beauty of us, we like I said, anybody can make a referral. We don't need a doctor's order. We don't care what kind of insurance you got. Generally speaking, the people that we do see they just have Medicare and they just have Social Security, so they generally can't afford to pay for private care, and they don't get all those wonderful services that you're supposed to be eligible for when you have Quest. But that kind of is the people that we see. And they fall into 2 main categories. One would be an elder person who's living alone and their kids or whatever on the mainland, and they're just kind of, nobody's realizing that they're slipping into self-neglect and dementia. And the other big group that we would get is people who do have a caregiver, but that caregiver is really burned out and really needs a lot of guidance and support. And so with those people who are all alone and don't have anybody, we're quite the private detectives too, and so we'll try to do what we can, like what you said, to build a team around them to take care of them, because we can't be there 24 hours either to help them, but we try to figure out what we can do. Our goal is always to help them to remain in the home for as long as possible, as long as it's safe, and in doing that, we focus on their health, trying to make sure that they're at their optimal level of health. Do they have a good relationship with their physicians? We talk a lot about health literacy too. We really explore with them what do they understand about their health condition, are they comfortable talking to their doctors? And then we'll be the go-between too. We'll get permission to speak to the doctors. We'll even say, how about I may help you make an appointment and I'll meet you there and I'll go with you. So we let the doctor, we're the eyes and ears for the doctor. And for children who are living on the mainland, we can let them know what's really going on in the home, and so that we can work from there to see what we can do to keep the person safe. One thing I did realize looking at this today, when you were talking about the Fs, we really focus on falls too, fall prevention. Every client should have, all the public health nurses should know, we have a very thorough falls risk assessment, and based on that, we try to intervene to prevent falls, because we know that can be a real game changer for a frail elder. And we just do a lot of things that you had just been talking about earlier, as just being, we care and we show that we care, and we listen, and we're very patient, and we do whatever we can. We love teamwork. We love to share the burden with others and communicate with other team players, and it just works for everybody that way. And I can't think if there's anything else that I'm forgetting to say.
How do they refer to you?
Oh, that's right. Okay, so to make it easy, I think, like I said, we go by geographical areas, and then the handout that's outside, it does tell the 5 sections that are on this island. If you kind of know where the client lives, you could call that section. I also brought some of our referral forms, and you could fill out the form and fax it to that section. If you're not comfortable, if you want to like maybe talk it over, would this be an appropriate referral, you can always call me at the Windward office, ask for Mary, and I could talk it over with you and talk about what I think the public health nurse could do, and also which office would be the right office to send a referral to.
Yep.
Okay?
Next, I'm calling up Tracy Wigton with the Mediation Center and the Kupuna Pono program.
Hi, aloha everyone. I'm with the Mediation Center of the Pacific, and we provide all types of mediation, but I'm here specifically to talk about our Kupuna Pono program. We know that conflict is a fact of life, and in particular when you're caregiving, family members can have ideas that are contrary to the caregivers. Families can have ideas that are contrary to what the elder person wants who's being cared for, and the list goes on and on. So we have traditional mediation as part of our Kupuna Pono program, where those specific individuals who are in conflict, we work with them through a mediation process. So essentially how it works is we bring them together with impartial mediators who meet with them together and privately, going back and forth, so they're not all sitting in the same room together, to see if they can identify and work through the issues that they're in conflict about. And it can be a broad range of things. It could be about money, it could be about difference of opinion of who's supporting the elder person, and on and on. That's the specific people who are in conflict. The other part of our Kupuna Pono program, which I'd like to focus on more, is our family conferencing process. And we designed this process in response to the calls that we were getting from family members, and it's generally the caregiver who's feeling overwhelmed, who either, one, doesn't want to say anything to his or her siblings because they feel that they don't want to be a burden and that's their responsibility and they're not doing their job if they're asking for help. Or it's other siblings who feel that the person who is caring isn't doing a good job, or that their elder parent or elder family member needs more assistance. So that process is different in that we're bringing everybody together, and we're facilitating a discussion based on what are the needs of the elder person, what are the values and desires of the elder person. So it isn't just about, 5 adult siblings getting together deciding, we think that mom needs to move out of her house and we all want to get together and make her do that. It's bringing out what's important and what that elder person values. And then together, having all of them come up with a plan that meets those needs, that meets those values, and meets those desires, and memorializing it in a plan. Now, that sounds really easy. It's not. And it's not from the perspective of, we really want people to access this service early. And unfortunately, people wait till there's a crisis. So it's, mom is now in the very late stages, we're all fighting about it, we're in overwhelm, we don't know what to do, and we're at each other's throat. And then mom can't speak on behalf of herself anymore. So not that we couldn't bring people together and have that family conferencing process, and we've done that, but we really want to encourage people to access the service early, as soon as there's a diagnosis, as soon as somebody's in the hospital because there's been a change. Maybe they've fallen and now they need more help. Maybe they're starting to decline and they need more help. It's bringing everybody together early when that elder person can speak on behalf of themselves. And unfortunately, people don't want to have those conversations. They don't want to have them, period, but they really don't want to have them early because they think, I don't need that. And so we really need all of you to be ambassadors to encourage families to access this. We've had families, now that we've been out promoting it a lot, start accessing it early. And they have conversations everywhere from what are current needs, and it may be as simple as, we're concerned about mom's driving, and it's a really tough conversation. Having that conversation to what kind of social activities, what other kind of support, what are your expectations regarding end-of-life issues? What do you have in place? Do you have a healthcare directive? Who has the power of attorney to make financial decisions if you're no longer able to do that? And what's your understanding as a family about what that means, and have you had that conversation? What we've seen a lot of times is sometimes you'll have the adults, the elders, go out, they have everything in place, they know, they've gone out and gotten their will, their trust. Maybe they have a healthcare directive and they have it in a drawer, or they have it locked up at home, and they feel good that they did that, but they never had the conversation with the rest of the family. So now you have siblings who are in dispute about that, or maybe they don't understand. So all of these issues we can work through a family conferencing process. So I have brochures that I'll leave out there so that you can pick them up, and I also want to leave it open for questions. Essentially, we are located very close by on the corner of Kukui and Aala Street at the Children's Kukui Center. But we also will go out into the community to meet with the family. So for example, if a family all lives out in West Oahu and Waianae, I'm sure they probably don't want to drive all the way into town. We will go out and meet with them out there. So we look for either a health center or a community resource center where we can bring the family together. We also have Skype access at our office. So sometimes some of the family members are off island, maybe part of the family is on neighbor islands, some of them may be on the mainland. We've even had people internationally, and they want to participate in the family conference. So we can schedule where the family members who are located here participate, and then we bring the other families in either via phone or via Skype, so that it can be a full family conversation. And again, it's based on what are the needs and strengths of this family, what are the values and desires of the elder person, and then working through each of the issues, and then they end up with a family plan that ideally they take back and they review the plan together and work through the plan and review it and update it themselves. But on occasion, they'll come back and want to do follow-up. So the last question I'm sure people are going to ask is, how much does this service cost? If anyone in the family, particularly the elder person, is in the low-income population, there's no fee. It's waived. If the family has financial resources, it's a flat $250 family fee. Our goal isn't about the fee. Our goal is encouraging the families to come in and have difficult conversations so that they can work together to support their loved one. So the fee isn't a barrier. It's more of people will value the service if they pay something. So we are very, very flexible. What our goal is to encourage more people to talk about it and talk about it early so we can have access. The families that we do work with, even if they're a little maybe uncomfortable or not sure if they're going to feel good about it, all have had very positive results and feel that it's been helpful. So I'd just like to stop and open it up for questions. Any questions? No questions. Okay, thank you very much.
Okay, we also invited the 4 hospice agencies. Island Hospice, is Scott here? Oh.
Hello, I'm Annabella. I'm a RN clinical liaison from Islands Hospice. Thank you for having us today. And focus on dementia patients in end-of-life care as well as Alzheimer's patient. So it's very quite challenging for the family as well as the patients and of course as caregivers and healthcare providers because it's a chronic condition. Either they go to the hospital for pneumonia or UTI and how much they can take. So it's very important, even just education, advanced care planning for us to discuss with the family. Not necessary to enroll them to the services right away, but at least they have that initial conversation about what we do. Because hospice is considered very supportive in assistance with the patient, family, as well as caregivers, and for us to as providing care for them. So our role as a hospice is to support and give that information how can they benefit the services. So either they could be at their own homes, foster homes, care homes, or nursing facilities to have that started. And it's for quality of life. And a lot of times our family members are not ready for hospice yet. So at Islands Hospice, we also have our program, Transitional Care. So we can give them information. We started this program July of last year, and we have quite a bit of patients that had benefited from it. So basically, we're here to support for a smoother transition, get the care that they need, because dementia, that's the best gift that we can give them, yeah? But we have information. Our team consists of RN case managers, certified nursing assistants, social workers, chaplain or spiritual care people, and trained volunteers. Yeah, so I do have outside our information, our basic hospice services, my contact information, and yeah, please give us a call if you need any assistance. Thank you.
Somebody from St. Francis Hospice? Christy, did they come? No, okay. Hospice Hawaii, Dr. Craig Nakatsuka.
Dr. Nakatsuka, one of the co-medical directors at Hospice Hawaii. I'm not going to actually talk anything about Hospice Hawaii, but really talk about some of the myths surrounding hospice, what people think about hospices, especially in regards to dementia or Alzheimer's dementia or the various subtypes that you have. And the thing about dementia is sort of that burning question, okay, what is end-stage dementia? When should we refer? The challenge for dementia as far as for hospices in general, yes, there is denial of that the disease is even happening, but it's really this situation where we all have some idea of how dementia will go, short-term forgetfulness, more confusion, after a while not even being able to recognize family members, getting weaker, not eating much. Aha, that must be about the place where we might consider hospice. And if it gets even worse and they're not even talking and they're not reaching bedbound, okay, then hospice must be a place where we put grandma, mom, etc., for which that person can just be made comfortable and die. Well, where geriatrics and Alzheimer's dementia intersect in a crashing crescendo is that a general principle of geriatrics is you won't know a 92-year-old from another 92-year-old based upon function, just on sheer age. You can have a 92-year-old who's still driving, taking a bus, and actually doing some part-time volunteering work, and you can have a 92-year-old that's bedbound. But what seems to be quite predictable, especially if you hit into your late 80s and early 90s, is that your physical and cognitive reserves predictably drop over time. And I used to tell families, because I do palliative care also, that you could come into the hospital with a stubbed toe, a 93-year-old who's fully functional, and come out barely able to talk, barely able to recognize people, etc., especially if they have Alzheimer's dementia. And then it really catches families and caregivers unawares, because they often would say, well, I knew that mom had dementia or early dementia, and I knew eventually there would be a time when there would be growing disability, that she would have to be somewhere if she's had all the education that you folks and resources that are being provided today as an awareness thing. But I didn't realize that this would come now. But that's the reality of what happens often with hospitalizations. Because of a loss of physical and cognitive reserves, especially pronounced in dementia, you can have someone coming out that is quite impaired, will not recover. Often they're referred to us straight from the hospital or after a stay in a skilled nursing facility where they're getting physical therapy and just making no progress, actually getting worse. And that's really a challenge for the hospice agencies, because you are then trying to talk to caregivers or family members who are quite unprepared. You know, even if they knew that their family member had dementia. And that's just what happens. And then again, as I said, we have to deal a lot of times with, hospice must be the time when we give up and finally they will just make grandma, mom comfortable and pass away. Actually, if there's any time for the team concept, it's really what the hospice agencies can perform, in particular for Alzheimer's dementia. And the reason being is that we are in a situation where by having such an array of support in various sectors of care for the patient, in particular in regards to their confusion and cognitive problems, delirium, agitation, etc., we have something that the most superb neuropsychiatrists around cannot have. And that is, with all the armamentarium of medications that we have today, which I have available to me, it's really the fact that you can offer music therapy, aromatherapy, massage therapy, and just talk therapy, and just presence that actually has no side effects. They're not like medications, and they contribute so much more substantially and significantly for the comfort and ease of distress and the agitation and the delirium as much as the medications, of which I know all about. And so that really is one of the large values of hospice towards end-stage dementia that can be offered. And then the philosophy is really to be able to allow the caregivers, especially their children and family members, to not have to be burdened with the distress of symptoms that hopefully with my expertise that can be well taken care of. And a son can be a son rather than just a caregiver. A daughter can be a daughter rather than just a caregiver. Relationships and the things that really matter can happen at the end. And I speak of this because I think of the next generation. If a son and daughter is or a grandson and a granddaughter is taking care of a loved one in their end-stage dementia, and it goes really well, which in the last chapter of their lives, believe it or not, we can actually provide something that offers dignity and meaning to someone, even in that situation, in the last chapter of their lives. It changes the perception and the confidence of the next generation of how things will go. So that's what hospice as a general philosophy and resource offers. Thank you.
Thank you. Representative from Bristol Hospice?
Hi, I'm Amy Melnikoff. I'm a hospice liaison for Bristol Hospice. So I'd like to thank Debbie and Christy for inviting us to come join you guys today. So Bristol Hospice is one of the 4 hospices. We've been here caring for patients on Oahu for over 10 years now. We see patients in their homes, in care homes, and in the nursing facilities. So about half of our patients reside in their home or care home, and about the other 50% of the patients are in nursing homes. So we have staff of very caring, compassionate, and very well-trained group of nurses and CNAs, social workers, much like the other hospices offer. We have 5 medical directors, and I'm proud to say that Dr. Rita Bell Fernandez is medical director for Bristol Hospice. So we have a great group of people here caring for our patients. Things have progressed both in healthcare and on the insurance side, where we're offering more than just traditional hospice nowadays. So we do have a supportive care service, which is for patients that may not be terminally ill. We also have a new program that we're going to be rolling out shortly that is not insurance driven, looking at those patients that may not be supportive care, they may not be hospice, but they still need to be supported by community resources. So we're just looking at how we can best utilize our staff to be able to support the patients here on Oahu. So I have brought some resources today for you guys to take. We will also leave our business cards. I have our nurse, Charisse, is here with me today. We can answer questions here or later, but I wanted to share with you just some of our dementia-related resources. So we have a nice screening tool that is showing the different stages of dementia. So you'll see impairment, treatment, and then the affected brain area. So typically we start seeing hospice patients being eligible for services around the stage 7A. So I left this out in the front. If you guys want more of these, grab our cards, give us a call. We can always get more in your hands. We also have resources for caregivers, educational material. So here is a Living with Dementia, a caregiver's guide to memory care. So I always tell our families, I really feel strongly that our service is just as much for the caregivers, for the families, as it is for the patients. So we really want to look at supporting the whole family. We also offer pre-bereavement. So as our families are preparing for end of life, we oftentimes will bring in our bereavement counselors early and help with counseling services. So please feel free to consider Bristol Hospice when you have patients who are at end of life or getting closer, and we'd love to be able to partner with you guys. So thanks for having us.
Okay, next I want to ask if the ADRCs want to come up. Lay or Zen, Andrea? Just really short about what you guys do. Thank you.
Hi. Hello. Hi. Hi, everyone. I just wanted to say, I noticed, also a side note, I noticed how thinner people look more up there. I hope I look skinnier up there, guys, because I had a little bit too much cookies today. So sorry for the ones down here. If you can't see my mouth talking about, you see my chins. No, I'm joking. Okay, so my name is Zen. I'm a supervisor with the Elderly Affairs Division, and this is Lei. who's also a supervisor in our INA center or call center. Sorry, I apologize because this was sprung up on me today, like 5 minutes ago. What are we here to talk about? No.
Okay, so we have community service workers and case managers that we man the senior helpline, and we also go out into the community and we do assessments, and we provide services to seniors that are 60 and over. Basically, we screen the calls and the referrals that come in. We get referrals from everyone. We have seniors calling in for themselves, friends and family, hospitals, agencies in the communities, and we basically screen the calls and we service the people that we're able to, and then we also provide resources and referrals to other agencies in the community. So,
just to talk about, I guess, the programs that we do, the main programs that we do offer, we have Kupuna Care. Under the Kupuna Care program, or with the program, we offer, or we have contracted services for bathing, Meals on Wheels, attendant care, homemaker, personal care, transportation, then we offer case management in-house. And currently, right now, we are also doing the Kupuna Caregiver program. And under that program, the funds that we're using the funds to pay for adult daycare. So as long as there's a caregiver working 30 hours or more, and also senior has to qualify with the being 60 and over and having 2 ADLs and or IADLs. Then that's the initial qualifications. They can request to see if they could get help to pay for adult daycare. Yeah. Oh, right. So also we are called the ADRC. Besides Elderly Affairs, we have so many names, but ADRC, and we have 2 numbers actually. The senior helpline is 768-7700, and the ADRC number is, anybody know? What's it? Oh, that's right, 643 ADRC. I knew that. Okay. Anybody has any or have any questions? Okay. I think to make referrals, we do have a fax referral form. So if any outside agencies want to make referrals for any of our Kupuna Care services, we do have a referral form. If you guys call our senior helpline, we can provide that to you. Because I don't think that our website currently provides the form. Okay. Thank you.
Okay, thank you. We're going to have a little exercise right now. If you could, in your packet, pull out the group discussion sheet. It looks like this, about Mr. Kitagawa. So it's on the right-hand side. I see our resources are leaving. Can we give them a round of applause for coming down and sharing their information with us? Thank you. I talked earlier about person-centered practice and how we're trying to train the staff at the doors to be more person-centered. One of the tools that we are training them is to do a more personal profile when they're presenting their clients. So it's not the medical model type of a form or information. We're asking them to present the client in terms of what's important to the individual. So what's important to means what makes them happy. And then what are the best way that you could support the person, and what are 3 things that the person would want others to know about them. So as you can see, it's a different way to present the person, but it's more person-centered. It's what is important to the person, rather than you, the agency, telling them what they need or what they should have. They're telling you, listen to what they have to say and what maybe is important to them. On the flip side of the page, you'll see 3 questions. And so Dr. Rita Bell Fernandez is going to walk us through the exercise.
Good afternoon, everyone. I know you would love to stretch and move around. We've been sitting in these seats for quite some time. So we're going to break into smaller groups and do this exercise. Anyone here from Kaiser? Okay, so Kaiser has a beautiful program, which is new, called Switch. And the Switch program says, know me first, treat me second. So this way, the case is presented. It's important to know the person, know what is important to them. So let's look at Mr. Kitagawa. He's living in his own home. My daughter Misty, who lives on the mainland but comes to visit me during the holidays, this is important to him. My son Brian lives on the Big Island but does not talk or visit me. My neighbors in Kalihi Valley are important, and going to the graveyard to visit my wife. So as much as this is a fictional case, this is also a very real case. I have worked many years in the Kalihi Valley, and you have a lot of seniors living alone who have children on the mainland, and so this case is designed on the typical scenes that we might find in Hawaii. So the top 3 things to know about me. I am organized and meticulous about cleanliness. I have diabetes, high blood pressure, and arthritis. My wife of 50 years passed away recently. Now, how to best support Mr. Kitagawa? Help me to get to where I want to go because often I get lost. Tell me your name because I have difficult time remembering names. Take me home if I enter the wrong home. Bring me meals so I don't have to cook because I forget to turn off the stove. Now, a lot of you who are in case management must be saying, there's a lot of things missing here. I would like to know more about Mr. Kitagawa. So we're going to break out in smaller groups and let's make a list of what else you would like to know, because this is not the full story. So when you do an assessment, what other parts of the history you would like to ask? And what are the community resources here on Oahu that we can support Mr. Kitagawa to help him continue to live at home? Because you know what people say, no one is ready to go to a nursing home. Everyone wants to stay right where they are, they want to live where they are, and they want to die in their own home. So how can we help Mr. Kitagawa? And what about his children? Would you like to support his daughter, Misty? How can we support his son, Brian? And think of the different doors. We have the no wrong door, and there are many players, and how could we incorporate the different doors and support this person through the no wrong door system? So I'd encourage you to be in groups of 8 to 10. You can spread out. You can use the area in the front. You can go on the lanai, stretch your legs, go out in the foyer. So please come back in 10 minutes. And then we're going to have some sharing from each group so we can brainstorm how to best serve Mr. Kitagawa. Okay, go ahead.
Okay, so if this case or referral came to the ADRC or Elderly Affairs, then we probably want to send one of our case managers in to see his living situation or how he is in person. We'd probably want to provide Meals on Wheels if he qualified, transportation, maybe even to KKV since he lives in Kalihi Valley. We also have RSVP programs, so they have volunteers that could possibly help him escort to the doctors or maybe even take him if they drive. What else? As far as how to support his daughter, we'd probably want to educate her on how that is doing. Find out if there's anyone who has power of attorney and who that person is if it's not Misty. Helping her or kind of encouraging her to become a little bit more involved in her father's care since he's living alone. And try to build a support network. And then lastly, so what steps would you take to refer support? Again, one of our case managers would probably go in, do an assessment, including the mini COG if he has not already been diagnosed with any dementia or Alzheimer's. And then from there, try to recommend or make referrals for him.
Beautiful, excellent summary. Give them a big hand. Thank you for thinking about doing the mini COG, and thank you for thinking about the RSVP volunteer program. Often we forget that we have these beautiful services and programs on Oahu. Great job. Okay, next group, what would you like to share?
We make sure they're connected to Dr. Fernandez. Well, I mean, he is from Kalihi Valley, right? So, I mean, if you know he's from Kalihi Valley, you know that Koko Kalihi Valley is available there if they have no services, or all the way up to the Mauna, so all the way up in the valley, because they have an old Aina too. So if he wanders and if they know who he is, they can help him get back, you know. But I guess one of the concerns was the family, you know, what does the family know about him now, because he's living on his own. We start a discussion with the family because the son's in a big island, and then you have the other daughter that comes every so often, but what do they really know? So kind of having that discussion with them. We just learned that the Mediation Center can provide some kind of help. Maybe we can connect to them. But we do know that Kikuyu Kalihi Valley has case management services there as well. We could use them. Finding out you guys have memory clinic, awesome. So many things for them. I mean, of course, the tools that we're learning about today are helpful especially if they weren't diagnosed at all. You know, if this is just totally brand new, and he's noticing that he's having a hard time and he's getting lost, what do we do from there? I don't know, anything else?
Great job. Thank you for sharing about, you know, referring to the Mediation Center and reunification of this family. Let's give them a big hand. Bringing this family together, bringing this family closer is really important to heal that relationship with Brian and Misty and uniting this family. What about if the person is a wanderer? Any resource that was mentioned earlier from the Alzheimer's Association that you can think of? Safe Return Program, excellent. So the Safe Return Program is a beautiful program. Typically an adult is declared missing after 24 hours. So you have to wait for 24 hours before the police will go searching for a person. In the Safe Return Program, we bypass this 24-hour waiting period. They have the photograph of the person, and all the first responders can look for the senior immediately. So it's a really beautiful program and costs about $50 a year. Often they might have scholarships that might help offset that cost. Okay, another group. Who else would like to share? Go ahead.
One of the other things that we're looking at was his, tapping into some natural supports, like his neighbors. He apparently has a really close connection with his neighbors, using them to, see if they could be like a contact person so he can keep in touch with his daughter on the mainland. Possibly have them be a place to check in. The other thing we're looking at is what kind of medical does he have? Because he does have diabetes, he has high blood pressure. We want to make sure that he is taking care of his health needs. Also if he has Medicaid insurance, possibly getting one of those ID bracelets that shows that, who he is, his health concerns, his health, things like that might be helpful as well.
Very good. Let's give them a big hand. Thank you for thinking outside the box and looking at the neighbors as part of the care team and thinking about PERS. Anybody living alone, PERS is very useful and a good safety measure for seniors. So great job, and looking at the insurance. So in this case, you don't know what is his insurance, right? So you want to find that out. When I was in Hilo on Monday, the group said, we're just going to send Mr. Kitagawa to the VA. And that would be lovely if we knew he's a veteran. So that's something we have to take in our history. We need to ask, are you a veteran? So thanks for thinking about insurance and all these valuable resources. Go ahead, let's have the next team.
Okay, let's see. I'm going to try not to repeat what
Thank
other
you.
groups have said. We wanted to know how often he sees his doctor. Does he take his medications properly? How often does he get his meds refilled? Because he may not be getting them refilled at all. We don't know. How is he visiting his wife's grave, if at all? And we should start a discussion on long-range planning. What if he couldn't take care of himself, or maybe he already cannot? How often has he fallen? Who does he trust the most? Let's see, his finances. Is he paying his bills? Let's see. We were wondering if he needed bereavement services. We don't know if he's, mourning still about the loss of his wife. One of the questions that came up was we should ask him the question that you brought up. We should ask him, what would you do if there was a fire? Because he's a risk. And anything else that you can think of?
Okay, great job. Let's give this group a big hand. You have thought about even more things like connecting him with the physicians, thinking about grief and bereavement, thinking about his finances, long-term planning, long-range planning. So these are all very important questions to ask and think about, right? And it's good to prepare. You want to hope for the best, but you want to prepare for the worst. So great job, team. Anyone else would like to suggest things that have not yet or been mentioned? Any other groups?
We're from insurance, health plan. So if he came through our door, we would do a functional level of care assessment to see what he can do and what he cannot do, and then we will refer him to services. If he doesn't have natural supports, and it sounds like he really doesn't on island, then we would send agency caregiver to help him with meal preparation or going with him to the doctor's appointments. It says that he's organized and meticulous about cleanliness, so we may send somebody in to clean his home if that's what he wants, and do shopping for him. Different types of services in home so that he can remain at home.
Thank you. Beautifully stated. This is great to provide him with cleaning of his home because he is a clean and meticulous person. And thinking about what you said, so that's really awesome to think about the health plan and how they can also help members who need care. Anyone else? Okay, you all have done a fabulous job with this case and group discussion. I appreciate everyone for thinking outside the box, thinking of this Mr. Kitagawa in such a holistic 360 approach from all of his physical, mental, psychosocial, spiritual aspect of this case. So give yourselves a big hand. Thank you.
Everybody, big breath in. Now pat yourself on the back. Yes, you've made it through the day. I'm going to talk to you just a little bit and then we're going to wrap up, so we're almost there. We're going to circle back to the benefits of a dementia-capable system. You really are the start of that. You know this. I'm so impressed with your case analysis. I was listening to that thinking, that's such great ideas. It's clear that you guys are caring and wonderfully trained people and professionals, and hopefully today gave you a little bit more tools for your toolbox so that you can be the best professional you can be, more aware with expanded skills and tools to help create a supportive environment for the person who's living with cognitive impairment and dementia. The more that you do that, of course, and the more we catch people earlier, the greater control people with dementia will have over their lives. And, you know, the more control people have, the more they're aware of what's going on, the fewer crises they'll have, and then the higher their quality of life, which is great. You can also reach out, of course, and impact the care team, the greater care team, by expanding the support system to neighbors and friends and church members. And as you do that, you create a stronger and more connected community. So a community that values and understands dementia, that values people with dementia and what they bring to the community, and that creates a supportive net for them. As your communities become more dementia friendly, so does Hawaii, as all of your communities knit together to become Hawaii, the best place on earth to live and have dementia. And as your state becomes more dementia capable, other states start looking to you to see what you've accomplished, how you've done it. And so the whole United States becomes a more dementia capable and dementia friendly environment, a better place to live with dementia. And that influences the whole world. So we may start with you today, but eventually we get to the whole world being a more dementia-friendly place. So it all starts with you right here today. I'm gonna talk a little bit or show you this video about being a dementia friend. All of you here are empowered to do a better job being friendly, a safe place for people to express concerns about memory and thinking, and to get connected to the kinds of services and supports they need if they have cognitive impairment or dementia. There's a movement across the country, you're a part of it, a tidal wave of people like you across the country and across the world really, who are moving toward a more dementia-friendly world. The secret, I think, to being a dementia friend is really quite easy. To me, it all boils down to three things that every single person can do. Be patient, be kind, be supportive. Be a dementia friend. And if every single person in our community understood a little bit about dementia and were able to be patient, kind, and supportive, what a great thing it would be. And how lucky we would feel that if we're one of the ones who get dementia, we're in a community that's gonna be patient, kind, and supportive with us. So I'm gonna play this video, it's one of my favorite. If you're a teary person, we should probably lower the lights so that no one can see if you tear up a little bit. I always do a little bit.
If you saw someone living with dementia, would you recognize the signs? Would you be uncomfortable? Would you avoid them? Would you be frustrated? Would you do nothing? Or would you be a friend? Would you engage them and empower them to get through their day? Would you welcome the opportunity to help them feel like a part of your community? Would you take even the smallest step to make their world less frightening or confusing? Every single one of us has a unique part to play in the lives of people living with dementia in our community. Become a dementia friend today and build communities where all people can live, age, and thrive.
Hey, Mr. Fredrickson, it's Tuesday. Aren't you going to the store?
Yeah.
Come on, I'll walk with you.
Find out more at dementiafriendsusa.org.
Now, you notice that the Dementia Friends movement is sweeping the nation. Really, this started in the UK and started spreading across the United States, starting in Minnesota. But Hawaii has embraced the Dementia Friends initiative, and each one of you can become a dementia friend and spread that around the community as you talk to people. This is a great way to engage bus drivers and restaurant wait staff and banking and all of those touch points in the community that we all use. If you use a service in the community, if you go to the grocery store, if you go to the dry cleaner, if you, whatever, all these things that you do, people with dementia do that too. So how do we create an environment where everybody understands a little bit and can be a dementia friend, be patient, kind, and supportive? So Dementia Friendly America has a great website and Dementia Friends where you can see little videos that show, if you're a bus driver, here's some things you should know. If you're a wait staff, here's some things you can know. But you can all go online and become a dementia friend. So I would encourage you to think about that and tell your family and friends to do it too. And I'll end with this. For a long time, for more than 10 years, we've worked on making our communities better places and friendlier places for people with physical disabilities. The Americans with Disabilities Act really opened the door for that and created some amazing things that benefit all of us. I think about curb cuts. The little cut in the curb that allows you to pull your luggage across the street when you're going somewhere. If you don't have a physical disability, it's absolutely necessary if you do, but it helps all of us navigate the city a little bit better. Doors that open when you walk up to them. These are all great things that we have because we've made our communities more accessible to people with physical disabilities. And I would challenge you to think about that now is the age of thinking about how to make our communities more accessible to people with cognitive disabilities and to reduce the stigma of having a cognitive disability by starting to talk about it, have conversations, and starting to see the world through the eyes of someone who might have a few more challenges cognitively, and change our organizations, our systems, our buildings, our structures, our cities, our networks to be friendlier and easier to navigate for people who have cognitive disabilities. All of those changes begin with you, and then your organization, your community, and you have a huge role to play. And I'll leave you with this. Never believe that a few caring people can't change the world, for indeed, that's all who ever have. I wish for you a dementia-friendly community so that when it's your turn or your mom's turn or your sister's turn, that person has a really good experience, good of an experience as can be had with Alzheimer's disease or a related disorder. And I thank you so much for being here today and for all you do every single day to make life better for others. Thank you so much. Thank you. You have in your folder a post-test and an evaluation form. We're a little bit early, so you have time to fill that out before the allotted time, so please fill that out. And where would you like them to leave it, Demi?
At the registration.
At the registration desk. So please take a minute to complete that and leave it at the registration desk. Anything else?
If you signed up to get CEUs for social workers, you need to initial that you stayed the whole day and initial the sign out column. It was a great day. I hope you learned a lot. We have been going to the different islands with the Barclays to present this training, and everyone has just totally loved what they had to offer. So please help me thank the Barclays for being here and for helping us become more dementia friendly.